All right,
We are
so the
recording, yeah.
recording has starting. I hope you all heard the alert
Okay.
from Kyle. So I will introduce Dr. Monica Kindy to talk to us. Her session is titled "A Leaky Pipeline: Addressing Racial Disparities in Medical Education." She is assistant professor of biochemistry, also at KCU. So thank you so much, Professor, for joining us today.
Thank you, Dr. Bever, so much. I just want to thank everyone for the opportunity to be here today. I also serve as the director of student success at Kansas City University College of Osteopathic Medicine. And kind of tangentially related to that, I do chair the admissions committee. So while I'm talking about addressing racial disparities in medical education, I am going to kind of look at this through the lens of medical school admissions. So you're going to see a lot of pulling in my own personal experiences and interests as I'm going through my talk. So I have a couple session objectives. I'd like to talk about why diversifying the physician population is incredibly important in the context of our modern social systems and healthcare. And then kind of related to that, describing challenges associated with diversifying the physician population, and then strategies that we can put into place towards that goal. So starting with a classic, The Giving Tree by Shel Silverstein. I think we all remember this as a classic children's book talking about selflessness and altruism, and modern the arguments both for and against The Giving Tree as a great book and a terrible book exist. But moving on from that, let's consider a social system, in this case represented by a tree, and the inherent nature of that tree, in this case the social system, the constraints by which it grew, arbitrarily favor a certain population over another. So these people here would benefit from the fruits of this system, but the general constraints favor one person over another, and we call that inequality. So recognizing that these people would benefit from the access to these fruits, we can put into place several solutions or resources that these people might be able to use to have greater access to the fruits of this tree. So natural is we would want to allocate equal opportunity, equal access to the same resources to the population as a whole as a fix, right? But that doesn't take into account that people have different needs, right? Whether or not I belong to a demographic versus another, those equal resources might not work for me. And even though that latter in this case works for this person, it's not working for that person. And so we would need, this approach represents equality. So while you hear a lot of discussions about equity and equality, I think I'm trying to get to the point why we talk about equity as a fair solution compared to equality. And so what equity does is it takes into account an individualized approach towards fixing an inherent injustice to a system. So the injustice here being that the tree is arbitrarily advantaging one population over another. But now the equitable solution would be to formulate an individualized solution that gives everybody access to the fruits of that system. So while it can be, using the analogy of the giving tree, it can appear that our system, our social system in this case, is naturally occurring. But we need to remember that the social system of our society is not naturally occurring. It has been built over decades and centuries. And that system, what that we live in, has been built on bias, privilege, racism, and prejudice that has allowed this system to arbitrarily, or rather very deliberately, favor one population over another. So these inequities, the fact that the tree is growing one way versus another, result in disparities. And as KCU being a medical school, we are interested in health disparities that might arise from these inequities. So these disparities include the quality of care a patient might receive, access to care of all levels, preventative, treatment, management, disparities in life opportunities and actual lived experiences, and of critical concern are disparities of clinical outcomes, or actually measurable health outcomes. So using a local example, I'd like to look at the Kansas City Metro. And so we're looking at a map of the KC Metro mapped by life expectancy. So you can see here the dark blue has the lowest life expectancy compared to the light blue, which has a higher life expectancy. So if we compare this life expectancy map to a similar map of the KC Metro, now mapped based on predominant demographic of the area, we can see, probably not surprisingly, that these lowest life expectancy areas are correlated with areas that are predominantly Black. Yellow here, you're seeing predominantly Hispanic. So looking more closely at the zip code 64113 and 64128, let's look a little bit deeper into what those zip codes are. So 64113, if you're familiar at all with Kansas City, it's the Brookside, Mission Hills area. It's 93% white, highest life expectancy of the KC Metro at 87 years, with a median household income of about 138,000, compared to literally 6 miles away. The zip code 64128 is 86% Black, has the lowest life expectancy in the city, and has a median household income of only 26,000, which is harrowing, to say the least. So we've got all of these domains that contribute to health outcomes: economic stability, your physical environment, how you're being educated, what you're able to eat, your community, and then your healthcare system. But every single one of these domains that directly contribute to health outcomes are affected by racism, prejudice, bigotry, and discrimination. So these inequities exist. They've been measured, they've been reported. Things like infant and maternal mortality, incidence of cardiovascular disease, and various preventative measures. Death rates from cancer are measurably higher for marginalized populations, as are incidence of heart disease and diabetes, significantly higher in populations of the historically marginalized. For the purposes of transparency, I've been perusing the American Medical Association's Guide to Equity. I've always comfortably used the phrase URM, underrepresented minority. I learned yesterday that that phrase is no longer preferable, and instead the preferred terminology is historically marginalized. So I'm trying to be very deliberate about using historically marginalized, but I'm learning, I'm trying to do better. So if I do use the phrase underrepresented minority, just know that it was in error. So things like a Black infant during their first year of life is twice as likely to die compared to a white infant. And then preventatively, a Hispanic male is less than half as likely as his white male counterparts to be screened for colorectal cancer. And so by extension of that, Hispanic males are twice as likely to be diagnosed with late stage colorectal cancer compared to their white counterparts. And what's interesting is even when we correct for things like insurance status, income level, age, and severity of health conditions, these disparities are still present. So I want to take time to also point out the importance of patient practitioner racial concordance. I would like for you to imagine, when you're sitting in an exam room, who would you prefer looking back at you? Is it somebody that looks different, or is it somebody that looks like you? I know if I'm at a OBGYN office, I would, based on my own comfort and experience, would prefer to be working with a female doctor. And that's okay. Those are natural degrees of comfort. And the same can be said about race. So Black populations, the historically marginalized populations prefer a doctor that looks like them. And it's actually interesting that the health outcomes are measurably improved when that racial concordance exists. So much so that the patients note an improved communication quality. So they're perceiving that the doctor is better at giving them information, which improves the level at which that patient is willing to participate. And it also improves the patient's intention to adhere to a management plan. And as I mentioned, overall increases the patient's satisfaction with the health encounter. And so, the other important thing about this is that physicians of color have shown a deep commitment to serving communities that are historically disenfranchised or underserved. So it's important that we're training student doctors who are from those historically marginalized populations. So having said all that, where are we? So here is a slide kind of outlining the population disparities that currently exist. So 30% of the United States population come from those historically marginalized population, where only 9% of practicing physicians are from those same populations. Let's look a little bit more closely at Black physicians. So while 14% of the United States population are Black, an abysmal 4% of our practicing physicians are. So this presents a very large gap. Of increasing importance is that census estimates by the year of 2050, we expect over 50% of our population to be from these historically marginalized populations. And while the diversity of our practicing physician pool is increasing, it is in no way increasing in a way that would keep up with that population increase. So why do these population disparities exist? Those same social inequities that are affecting household health outcomes are affecting our pool of available students. Some general weaknesses that we discuss are passive recruitment and passive targeted exposure of these historically marginalized students to the field of medicine and just healthcare in general. They're getting woefully inadequate preparation, both professionally and academically, and fundamentally they lack a multifaceted support system. So really, they're just not being exposed to the possibilities, and so then they just go through the public educational system, just assuming that, being a doctor is out of reach for them. So I'm trying to advance. So the other important thing that I wanted to point out here is I talked about racial concordance between the physician and the patient. Those same racial concordances are super important when you talk about student teacher too. So, as students go through the public education primary system, they very rarely will see teachers that look like them. And that problem becomes even more pronounced as they move into post-secondary education and then finally undergraduate medical education, where, if only 4% of our practicing physicians are Black, if I am a Black student going through undergraduate medical education, it becomes increasingly difficult, if not impossible, for me to find that professional mentor. So we have a leaky pipeline, right? So this is the kind of continuum that a student would experience as they go on the path to becoming a physician. But these leaks exist at every level of education that they would be required to experience. So again, lack of mentors, they don't have the access to resources. I think everybody here knows that urban, highly diverse public education schools have less access to resources. They might not have the college preparatory coursework. They don't have the ability to take AP courses. And so their interest in medical education, just right off the bat, is already kind of at a minimum. So we want to be able to address those leaks that in a way that addresses both the leaks themselves and the pipeline itself. So we can increase the pool of predoctoral students that come from historically marginalized population. We can increase those faculty that look like students who have been historically marginalized. And interestingly enough, it wasn't until the 1978 that the Association of American Medical Colleges, or the AAMC, kind of came out formally and said, hey, maybe we should partner these medical schools with these institutes of education, so that maybe we can, increase the diversity of these pools. And despite coming out with that formal recommendation in 1978, surprisingly, very little has been done since then to do any tangible work towards that. There's also, I do want to point out, this lack of interest is also kind of deeply woven in this idea of psychological safety. So historically marginalized students have deeply ingrained cultural norms and expectations of them. So if you are predisposed towards academic excellence, you might, for the purposes of self-preservation, might be less likely to strive for those performance levels because you don't want to be different. You don't want to act white. And so students who do have that capability or that prowess or that desire to pursue this very rigorous pathway might be disinclined to do so because it would be ostracizing themselves from their local communities. So in terms of recruitment initiatives, and sorry, I'm going to backtrack a little bit. So there is a preponderance of literature out there that focuses on this K through 12 pipeline, the post-secondary pipeline itself, but looking through my own lens of experiences with undergraduate medical education and medical education medical admissions, I'd like to kind of focus on, this transition here. And specifically, what are some recruitment initiatives that we can adopt that would address this significant disparity in physician diversity? So regardless of the recruitment initiatives that exist, you will see some core elements that tend to exist in terms of role modeling, motivation, academic enrichment programs, that professional mentorship, and then other opportunities that students might otherwise not have. So the AAMC, as I mentioned, was working towards this goal of diversifying the physician pool, so much so that in 1991, they launched this project called 3,000 by 2,000. And as it says, they wanted to educate 3,000 student physicians who come from a diverse background by the year 2000. Just to kind of give you an idea of some of the challenges that diversifying physicians exist, they got about 2/3 of the way to their goal. So yeah, that kind of speaks for itself. So other recruitment initiatives center around the creation of magnet schools, articulation agreements that exist between area hospitals and area institutions of higher education, and then these science education partnerships. One program that has been developed at the post-secondary level that has been very successful, you might have heard of, is the Meyerhoff Scholars Program. This was developed by the University of Maryland, Baltimore County. And it is specifically a STEM-specific pipeline for diverse student population. So they've graduated about 1,400 alumni, and they have an astonishing 87% success rate. And that is so successful that this same Meyerhoff program has been replicated at a variety of other schools. So just to give you an idea, this program has graduated students that have gone on to earned 367 STEM PhDs, 180 MD or DO degrees, and currently 370 Meyerhoff scholars are enrolled in either graduate or professional programs. So again, you're looking at the 13 core tenets of the Meyerhoff Scholars program. And again, it looks similar to some of these core elements that we've discussed before. One thing that other core recruitment initiatives lack that the Meyerhoff program adopted is this financial aid. So Meyerhoff scholars are guaranteed 4 years of full tuition payment. The other thing that's unique to the Meyerhoff Scholars Program is this idea of a summer bridge program. So Meyerhoff scholars are brought to the area either 6 to 8 weeks early, so that that dedicated time period can serve as a leveling opportunity for these students who come from a variety of school districts, a variety of different lived experiences, cultures, to give them time to form those super important community bonds so that they can be successful during their experience at the University of Maryland. A similar program has been developed at Hofstra University, which serves the New York City Metro. It's called the Medical Scholars Pipeline Program, but it is very similar to the Meyerhoff program itself. At KCU, we have some of our own kind of homegrown initiatives. Last year, we announced the formal partnership with Harris Stowe State College in St. Louis, which is a historically Black college. And we've kind of created our own mini pipeline for these underrepresented students. So they are offered a position in our Master's of Biomedical Science program. It's a 1-year program. And then if they complete the master's degree with at least a 3.5 GPA, not even having to complete the MCAT, they're guaranteed a seat in the College of Osteopathic Medicine. We also have another KCU Grown initiative created by our own alumnus, Dr. Renee Darko. It's an app, the Med Ed EQ, which connects historically marginalized pre-med students directly with KCU admissions representatives and faculty. They are able to hold virtual recruitment events, give one-on-one feedback about their admissions application. They are able to conduct mock interviews and really fill that mentoring gap that many of these students come into KCU with. The other great thing about these initiatives is that we've got a national organization whose sole mission is to increase the diversity of our physician pool, and that's the National Medical Association. They are the collective voice of African-American physicians and are a strong voice for parity and justice and the elimination of disparities in health. But again, their goal is to create a diverse healthcare system. And not surprisingly, they have said that preparation for students moving in to the medical education pipeline is that preparation should begin very early. So that recruitment needs to be happening in the elementary context, and they need to have continued support throughout. So again, looking at these leaks, I would like to focus now on the undergraduate medical education experience, particularly the admissions process. So if we're to address this lack of diversity in both medical education and the practicing physician population, what are some strategies and programmatic changes that we can implement to achieve this diversity? And I would say that it would be very difficult to develop meaningful strategies and promote changes without a good understanding of barriers or inequities that exist for these historically marginalized students. So I've already talked about the lack of mentorship. It can be exceptionally challenging just to find a faculty member or a physician that looks like these students from historically marginalized populations to serve that mentorship role. Something that I had personally, in my very privileged position, never considered are financial concerns. So there are a tremendous number of hidden costs that are associated with just applying to med school. So you're paying an application fee, you're paying an application fee for the secondary application, you're paying to travel to your interview, you're paying for a professional outfit, you're paying for hotel accommodations, you're indirectly paying to get away from work to be able to travel to that site. Something that I've observed from a chair of admissions committee are through the COVID process is when we transitioned to virtual interviews, our pool of lower socioeconomic student pools has increased significantly. You're seeing through the application process students that have come through a tremendous amount of adversity just to be able to get here. Students who come from single family households, students who have been working 2 and 3 jobs throughout undergraduate just to be able to make ends meet. Students who, because the pool of first generation students that we've seen applying to medical school for the first time has just expanded exponentially with the transition to virtual interviews. So while we might have collectively administrators who are excited to see everybody transition back to in-person life, there are certain elements of our day today that really benefit from the virtual experience, that I am going to do everything I can to make sure that we're keeping some of those. There's also this very traditionalist habit to overemphasize academic metrics. You know, doctors have to be smart, so they have to have good GPA and good MCATs. Well, I would argue that that's a very slippery slope to adopt, and I can show you why on this slide. So we're looking at average MCAT scores and average undergraduate GPAs of students applying for med school. And so you can see, without very much extrapolation here, that Asian applicants and white applicants have academic metrics that are higher than those of these historically marginalized populations. And if you sit back and think about that for a while, and even not for a while, I think that makes a lot of sense, because some of these historically marginalized students might not have had adequate finances or time to devote to studying. They're the students who are working 2 and 3 jobs because health outcomes suffer so significantly. Perhaps they're being a full-time caregiver to a grandparent or a parent. They couldn't pay for that fancy MCAT prep course. They couldn't pay for that MCAT study book. They couldn't pay for the individualized tutoring that helped them, achieve that super high MCAT score. So there are really complex and important social disparities that exist for these students, that when we are arbitrarily championing academic metrics, you're already kind of cutting the diversity of our available applicants. So again, to be able to implement meaningful admission strategies, you have to have a good understanding of these inequities that exist. So I'm looking through the literature, trying to understand, what we as KCU can do. And surprisingly, the Ohio State University did something several years ago that really had some very significant results. So their population of URM students as of 2009 was 13%, but implementing targeted admissions practices that sought to increase their diversity over the span of just 7 years increased their student body by up to 26%. So they very kindly summarized some of their admission strategies and published them. And so looking at these strategies and these recommendations, I could kind of look at and see what we at KCU have already done. And so I've highlighted those in green. First and foremost is crafting an admissions mission and vision statement that speaks directly to diversity. So I'm pretty proud of the mission statement that we came up with. It was a multi-team effort, literally took months, but I'm proud of what we were able to put together. And really what our mission is championing is that, yeah, academic success is important, but so are lived experiences, clinical exposure, leadership skills, community involvement, and even just saying explicitly, we actively recruit minority students. As a minority student that might be reading this or looking into KCU, maybe their MCAT's a little bit lower than they want, maybe their GPA. And so they're like, I don't even know if it's worthwhile applying. Reading something like this might be enough impetus to allow that student the comfort to say, you know what, I'm going to give it a shot. So we were really intentional with using these words here to say that we are actively recruiting minority students. And really, we want to make students know that might be applying to KCU is that we're not looking at their academics specifically, but we want to recruit students who show potential to be a successful doctor. That's fundamentally what we are looking at. So something that they recommended that we are not doing is implementing anonymous voting, which when I read that was kind of duh, right? I can see actively in admissions committee groupthink happening. So taking away that public voting and really allowing an individual to vote with their conscience without being swayed by their peers, I am absolutely 100% going to implement this for the upcoming admissions cycle. And I'm really curious to map that to outcomes. Creating a sizable pool of screeners is so hard. Many institutions are woefully under have faculty and staff numbers that are much lower than what we need to be able to do our job. So number 3 is very difficult to obtain. Number 4, adopting a holistic review is so important, so much so that the AAMC released a formal statement and strategy about implementing holistic review in the admissions process. What that does is it aligns, aligns the admissions process and takes into equal account a applicant's experiences, personal attributes, and academic metrics, but they're also focusing on what value an applicant would bring to the learning, practice, and teaching of medicine. So again, taking into account an applicant's whole application package rather than just looking selectively at academic metrics, because let's look at some physician traits. I think that we would agree that these are some traits that we would want to see in our own doctors, okay? When we map those traits to elements in an application, surprisingly, the only thing that maps directly to academic metric is the intellectual ability of an applicant. All of these things, all of these important EQ kind of traits, those are hidden within the application. So how a student is responding to secondary prompts, how they talk about their most profound failure and what effect it had on them, how they moved on from that, how they articulate their motivation to be a physician, what their LORs are saying about them and their character, what things they place value in, like what extracurriculars they're involved with, what healthcare experiences they've sought out, what things that they're volunteering for, what work experiences do they have. You know, the running joke at KCU is that the admissions committee is the hardest working committee on campus. And I think this kind of points to why, because it's not just a matter of double checking an MCAT and a GPA. It's about taking a really deep dive into every single application so that you can have a good understanding of what that student brings to not only our institution, but to the practice of medicine. Blinding interviewers to academic metrics, that was a really hard one. That again, kind of defaulting to that traditionalist approach. I have to be able to see who I am interviewing. I need to know how they did in undergrad. Well, no, you don't. You know, the interview is we want you to assess an individual's interpersonal attributes. So don't focus on their metrics. Tell us what you think of them. So about 3 years ago, we did blind our interviewers to academic metrics, and we adopted a pseudo MMI interview format. MMI has been touted as embracing holistic interview practices. The outcomes of that are to be, argued, and they remain to be done so in the literature. But really, this has been brought about some important measurable out changes to our interview process. Training our committee on the idea of implicit bias. Our admissions committee as a whole undergoes a 1 3-hour training on implicit bias a year, but that's obviously not enough. Implicit bias is something that you don't just learn. Implicit bias is something that you're actively learning about, working towards improving. It's kind of the classic example of the Dunning-Kruger effect. So I know all about implicit bias and I don't have biases. Well, I would probably consider myself at the peak of Mount Stupid if I thought that. And it is until that you learn more and more about implicit bias that you find yourself down here in the valley of despair and be like, man, there's so much I don't know about implicit bias. And that's why learning about implicit bias is a continuous process. A recent study just pointed out that the people who are most racially prejudiced, the most racist, consider themselves least or less racist than their counterparts. Although, again, there you go, right at that top of Mount Stupid, right? Something that has been recommended that seems pretty obvious is removing applicant photos. I would say that that is a standard practice amongst most institutes of higher learning. And then number 8, appointing groups with less implicit racial bias to admissions committee. That includes women, minorities, and by default younger people. I will say that our admissions committee is about 1/3 representing historically marginalized groups, which is great, but it's just not enough. And then I'm excited to share that over 50% of our admissions committee are women. And so diversity, women in medicine has been really moving profound mountains over the last couple decades. But again, we're not there yet. So there is still work to be done. So that's kind of where we are in terms of KCU and our various admissions initiatives. So let's look at where we are. So this is some COM metrics for our typical KCU student. So again, average science GPA right on par with your other osteopathic institutions. Average MCAT of 505, that's right on par with other osteopathic institutions, which tends to be a little lower compared to allopathic programs. But this is something I'm personally and institutionally very proud of. Is about 13% of our COM students right now identify as historically marginalized. And that's sorting through 5,700 applications every year, conducting 1,500 interviews, and matriculating a total of 432 students each year. So I want to give a little bit of context to this number here, show you just how far KCU has come. And so even, just a couple years ago, we were 2%, 3%, but really after we became more intentional with our diversity increasing initiatives, did we see this increase in the diversity of our KCU COM students. So we worked really hard towards that. And again, it has a long way to go. And we hope to just keep getting better. So we've talked a lot about the social systems in place and how they are inherently unequal, but also unequal in the populations that they deliberately favor. So we've talked about being equal in our response to that inequality and how equality is not the appropriate solution, but rather equity is. So looking at individuals and giving them the solutions and the resources they need to benefit from an inherently unjust system. But let's take this a step further. What if we instead of putting in place solutions, what if we made profound and transformative changes that didn't just seek to put in solutions, but sought to instead fundamentally change the system in place? That is what we call justice. And in this case, we've really we've wedged these 2x4s in, and we've righted the inherent wrongs to this tree. And so we can kind of look at it from the lens of our leaky pipeline. So what can we do to patch these leaks? What sort of initiatives can we develop to address inequities at every single step of this medical education pipeline? And then in the end, what we would like to do is fix those leaks completely, right? Stop the hemorrhaging of students out of this pipeline, and instead end up with a very robust and diverse practicing physician pool. Because right now, we are so far from being there. Really, it would be hard to get worse, right? So what can we do to keep addressing these profound inequities and give the same opportunities for students from historically marginalized populations? So thank you again to the organizers and my colleague, Dr. Dennis Winslow, who gave me the opportunity to talk about this that I'm very, very passionate about. Thank you to my department. We're a group of 5 strong, opinionated, motivated folks that I am amazingly privileged to work with. The KCU admissions team, who work tirelessly year-round on those recruitment initiatives. And then, of course, the hardest working committee here at KCU, the admissions committee itself. If you would like a copy of these slides, feel free to scan this QR code and it will download automatically for you. Thank you so much for your attention, and I welcome any questions that you might have.
Hey, I just want to step in and say thank you so much. And I know we got a little bit of a late start, so feel free to take some time in this session to ask a couple of questions if you like, and then we can join in the main session. And it's okay if we are a little bit behind on that. Chris is okay waiting because we originally had him scheduled much later in the afternoon. So thank you once again so much. And I'm sorry that I was in and out of both sessions.
It's hard to be 2 places at once, right? But thank you for joining. And if you don't have any questions, that's okay too.
Well, I just will say, when Monica says it's the hardest working committee on campus, it is. Yeah. It is, without a doubt. And they are great about keeping faculty updated about the changes and the new initiatives and kind of like the focus. So it not only is them working, but they do a really great job of letting everybody else know, kind of, and bringing everybody up to speed on what the goals are. So it's a good system. And Monica is that system.
Well, Dr. Dennis and I served together on the admissions committee for several years, and she was an absolute champion for diversity, both at the university level and at the committee level, which is sometimes that second voice is what you need. And so we were that second voice for each other frequently.
Yeah, the anonymous voting, anonymous, not unanimous.
Yeah.
Anonymous. I mean, unanimous is great too, but the anonymous, I mean.
So easy. Obvious, right? So obvious.
Just, wow. So good. Great job, Monica.
Thanks.
I want to just say a couple of things too, Monica. This was a fabulous presentation for me as a medical sociologist. And so thank you for pulling it together. I definitely want to get a copy of your slides. And although, you know, we all have a long way to go, I was really impressed by the the data that suggests something significant happened in 2016. I don't know when that was when you were put on the committee or not, but to me, addressing the implicit biases and then for sociology, it's like study first and then act second. And that's exactly what you've done, is that you've taken both the literature review as well as specific information to your university and this region, and translated that into some specific initiatives. And I just really applaud you for that. So it's hard to know which initiatives are working the most. You know, where are you and those students that you represent, where are they getting the most bang for the buck? But if you had to say any one initiative and or academic focus makes the biggest difference, what would that be?
Oh man, Ree, that's hard. I can speculate. Honestly, the virtual interview has had a profound effect. Absolutely. Just the widening our pool of students who otherwise would never have been able to interview here is amazing. And I think you see the effect of these historically marginalized students being able to apply to and interview for more schools than they would have otherwise, which increases their opportunity for an acceptance, which just inherently it would increase the diversity of the medical education pool. Also, and having that BIPOC voice on the admissions committee, I think is critically important, because I think I could speculate why, but I see in our committee discussions, hearing the lived experiences and the perspective of those BIPOC committee members, I think it is enough to sway that vote sometimes from the more traditionalists who want to stick to the black and white metrics.
Mm-hmm.
And that's just me.
Yeah.
Speculating.
Yeah. Thank you for bringing that information.
Yeah.
To us. Appreciate it.
Thanks for being here, Ree.
Okay.
Thank you guys so much. I'll see you back in the main room. Bye.